a little bit different than what you saw on the folder that went out. We kind of changed it midway and to make it a little bit more inclusive, and there wasn't a chance to make that change. So when I'm talking about a screening for dementia, and I'm going to do it in the context of the Mini-Cog, which includes the clock drawing test, and try to give you some very practical direction as to how to screen for dementia in the community. 1 second here. So I don't have any relevant disclosures. And generally, these are the objectives. I'm going to review the need for cognitive screening in older adults. And I'm probably preaching to the choir here. You're probably all aware of this, but I just want to make sure everyone is on the same page. I'm then going to go over specifically how to give the Mini-Cog, which hopefully some of you are giving, and the clock drawing test, give you a little bit of a background in the clock drawing test and why it is so important a part of evaluations that we do, both as a screening instrument, and we also use it as part of our neuropsychological battery at Northwestern. And then you'll observe some examples of the clock drawing test, just so you can have some comfort level with it. So you went over the pre-test already. I'll skip over that. So why do we need to look for memory loss? We have to be alert for the possibility of dementia because it is out there to a greater extent than most people realize. And this is especially an issue with physicians with established patients, or counselors with established patients, psychologists with established patients. And the reason for that is dementia starts very subtly. And very importantly, social skills are often intact, in my experience, through even the beginning of moderate dementia. So if I was to meet somebody with, the beginnings of a moderate Alzheimer's at a cocktail party, unless I spend enough time with them, there's no way I would have any idea that they had a dementia. We're talking about the weather, it's been kind of rainy, and that kind of back and forth. Their social skills are going to, in most cases, be impeccable, unless they have one of the less common dementias like a frontal temporal dementia. But if they have something like Alzheimer's or a vascular dementia, you're not going to notice anything. And especially with an established patient, you might just assume that, old Fred's the way Fred's always been, and he's got his quirks and nothing to worry about. Those are the ones that we have to be very vigilant about so that we don't miss something, especially early on. Remember, with these dementias, we don't have a cure, but we can certainly increase the person's quality of life. And in some cases, for example, with Alzheimer's, we can slow down the degeneration that's occurring. Another thing to be aware of is often the patient is not aware. So some family members and even professionals mistake this as denial. I just saw, for example, an 88-year-old retired pediatrician, and his doctor, who's a very good primary care doctor, said, I want you to test him because he's denying that he has any problems with his memory, even though his wife is telling me that he does. And if you test him, maybe you can find out, does he really? I think he's just denying any problems. Well, he's not denying it. He's actually got damage to the brain that is keeping him from having the insight that there's a problem. So these patients are also not going to come to the office and complain that they've got problems with their memory often. And in fact, if you ask them directly about the memory, they might say, oh, I belong to a coffee clutch and everybody's got the same sort of forgetting that my wife says I've got. It's nothing. And that's the other important part. If you can talk to a family member, whether that be a spouse, an adult child, a caregiver, talk to them, get their opinion. And the way I introduce that so that the patient doesn't become upset is I basically say, look, the brain is so complex. You're seeing me here, you were referred by your doctor for some memory concerns. The brain is so complex, all opinions that we can get will help me do a better job. So you might be seeing one thing, your wife might be seeing another. Doesn't mean you're right or you're wrong. It's just giving me good information. And until we do an evaluation, we don't know what's important. So I'm honest with them and I explain why I'm doing something. And as a result, I find most patients are pretty cooperative. And then keep a screening measure at hand. It's not enough to just go with the gut feeling. And so the common screening measures we see out there are the Mini-Cog, the MoCA, which is the Montreal Cognitive Assessment, the Folstein Mini Mental Status Exam, the clock drawing test, either as part of the Mini-Cog or part of the MoCA or a standalone, and animal naming. So why do we want to do a cognitive screen? Look at this percentage. This is the percent of seniors receiving a regular cognitive assessment during their routine health checkups. 16% of seniors. And every time you see a doctor, you get a blood pressure reading, right? Look at that, 91% of the time, blood pressure, 83% cholesterol, 80% vaccinations. Hearing or vision loss, it's at 73%. I really don't believe that, but I don't think it's that high because most of my patients usually have hearing problems. Diabetes, cancer, and then look at this, memory or thinking, 16%. That's scary. Now, why? Why is this occurring? Part of it's time constraints. If you give a mini mental status exam, you're looking at 10 minutes ideally. You're looking at 15 minutes with some of my patients. If you give the Montreal Cognitive Assessment, you're looking at 15 minutes ideally, longer with some patients. So there's not enough time often, certainly not during a regular visit. It's also not part of the usual routine. And in fact, a lot of physicians have a lack of confidence either in their own skills or in how accurate the tests are. So for example, we've had the experience, I work with a behavioral neurologist, and we have neurology residents who come and rotate with us just to get some experience in cognitive problems, dementias, normal aging, that sort of thing. And we've had more than one resident say, we've had nothing on this. We had one that really stands out, and this was like in June. He was going to go in independent practice in just a month or two. And this is the first time he's being exposed to this. So people are not, unfortunately, learning enough about cognitive problems. They're very good with what they do learn, but they're not getting enough on cognitive problems, and often not enough on geriatrics in general. The other problem is clinicians are often worried that they're going to offend the patient. And going back to what I was saying earlier, just tell them what you're doing. Tell them why you're doing it, and I'll say sometimes we've got some very subtle changes cognitively. So I just want to give you a couple tests that are going to tell me, is there anything going on? You might find some of the questions really easy. Please don't be insulted. You might have some trouble with some. That's okay. So just kind of introduce it that way. And I've been doing this for 26 years. I mean, I've only had a couple patients get really angry. So knock on wood, that's been pretty good. And here is a wonderful opportunity for physicians to be able to look at cognition. That's the annual wellness visit. One of the things I'm seeing, at least in our practice with our primary care physicians, more and more are giving the Mini-Cog. The Mini-Cog is the one that's the 3 words clock and then the 3 words again. So it's a brief test, and I'll talk about it further. But a lot of physicians are including that in the annual wellness visit. Unfortunately, there's a percentage of physicians who have a template where the patient is alert and oriented, no cognitive complaints, blah, blah, blah. And because of time constraints and because of what I just talked about, being uncomfortable with it, they're really not doing something that is helpful. So why are we looking at this? Let's look at dementia. What does dementia mean? And this might have been defined earlier, and I apologize if I'm repeating things, but I want us to be on the same page. So dementia is not a specific disease. Think of it as an umbrella term, more like a syndrome, under which a person meets 2 criteria. Criteria number 1 is they're no longer able to take care of themselves. So we do a functional interview using the instrumental activities of daily living. So can they independently plan, prepare, and serve a meal? Are they able to manage their financial affairs? Can they manage their medications and take them at appropriate times, and so on? And the 2 that we find tend to be the most sensitive are the 2 on finances and medications, although the finances one can be tricky because sometimes another spouse has always done the finances. But even on that one, on the form that we use, as long as they can understand a financial transaction, that counts as being independent. So criterion number one, are they independent in the instrumental activities of daily living? Criterion number two is that on formal neuropsychological testing, there are 1.5 standard deviations from normal aging. So almost all of the neuropsych tests we give will correct for age. Some also correct for years of education, like the MoCA, which is a screening test. You add 1 point if the person has 12 years or less. Ours tend to be a little bit, I would say, more sophisticated, depending if someone has 6 to 8 years of education, 8 to 12, and so on. So if they meet those two criteria, so they've got loss of independence in their daily life, and secondly, they have cognitive deficits, then they qualify for what we call a dementia. Now, we go down two roads if somebody qualifies for a dementia. One road is looking at what are some possible reversible, hopefully reversible causes of this presentation, or at least modifiable factors like a low vitamin B12, abnormal thyroid, they have an infection, a sleep disorder, untreated sleep apnea, something like that. The other road we go down is what is the most likely disease that's underlying it. And if you look on the left here, the one that's most common is Alzheimer's disease. And the reason it's got that range 50 to 75% is some cases of Alzheimer's are pure Alzheimer's, some are Alzheimer's combined with vascular, Alzheimer's combined with Lewy body, and so on. But Alzheimer's is by far the more frequent underlying disease that we see. And that, of course, involves rapid forgetting, at least one other area affected. And to meet the criteria, they're no longer independent in the real world. The second one here in this diagram is vascular, but actually vascular and Lewy body are pretty much even as to how common you might see them. Again, there's a range here because they can be combined with Alzheimer's, for example. But vascular is any disease that's affecting the blood vessels, essentially. So you've got heart disease, stroke, combined with other diseases that can also impact negatively the blood vessels, like diabetes, untreated sleep apnea, and so on. So we look at those. Lewy body is a type of Parkinsonism. And when you think of Parkinson's disease or the movement disorders, think in terms of not only the movement part, the movement disorder, but think also of the non-motor part of a movement disorder. And in this case with Lewy body, it's the non-motor, it's the cognitive deficits, a lot of hallucinations, waxing and waning attention concentration. And then we have less common ones, frontal temporal dementia, primary progressive aphasia, which is a language disorder. It looks very much like a stroke, but it's progressive over time. So that's a dementia, meets the two criteria. I just want to mention one other disease, and that's mild cognitive impairment, MCI. So MCI is when only the cognitive aspect of dementia is met. So on testing, a person is outside of the normal range for their age cognitively, whether that be memory, language, visual, spatial, executive functioning, but they're doing okay in the real world. So they have a memory problem, but they've got an iPhone, so they've got an alarm that goes off all the time, and it keeps them going. They pretty much take their medication all the time. So it's mild cognitive impairment. And that was described by Dr. Peterson of the Mayo Clinic. And it's kind of, in most cases, an intermediate stage. So if, depending on the research study you look, about 20% of people with mild cognitive impairment, MCI, will evolve into a dementia. But it's definitely something we want to keep an eye out for and something we want to look at, because if somebody does have something like MCI, we want to make sure they've got things in order as best as possible. Do they have a power of attorney for healthcare and so on? So very, very important. Go on to the next slide. What's the biggest risk for Alzheimer's, which is the most frequent dementia? Getting older. So look at that, 75 to 84, 20%. Over 85, almost 50% of people over 85 have Alzheimer's dementia. So going back to why we need to be screening people in the office, this is so important, because if they're older adults, there's a good chance they have at least the risk. There's a good chance they might actually have the beginnings of dementia. And the earlier we can catch it, the more we can do. The 3%, 45 to 74, in our clinic, because we're a specialized clinic, unfortunately, we've seen a lot of patients late 50s, early 60s who have Alzheimer's. And we haven't been able to figure out why we're seeing that. But because both of us were in a previous health system, and I would say our average age that we were seeing was probably 75 to 80. And we've got a younger cohort in the western suburbs. So individuals over 85 are the fastest growing segment of society. Us baby boomers, we're the ones to blame. So there's more and more of us, which means there's a greater chance of seeing dementia in your practice. So what can you do in the office? Well, historically, it's been the mini mental status exam, right? And as I was talking earlier, problem with it is 10 to 15 minutes to administer, but there's also some cultural issues. So no ifs, ands, or buts does not work if English is a second language. Serial sevens, if you've never been good at numbers, and I've had some people who are worse than not good at numbers, they either have a learning disability or they get very anxious. So then you give them world backwards, but maybe they're not good spellers. So it's got that sort of issue. But here, look at point number 3. I have seen many patients with a 28 out of 30, 29 out of 30. They're retired teachers, retired physicians, retired professors. They have full-blown Alzheimer's, and yet they have a normal score, a really good score on the mini mental, because we use a 26 as a cutoff. So that's a big problem with it. You're going to miss patients. It takes you a long time. The other problem is it does not assess executive functioning. So executive functioning, of course, is things like organization, attention, concentration, planning, decision-making, judgment, things like that. It does not assess those areas. And the problem with that is in many dementias and cognitive disorders, that might be the first thing you're seeing. So for example, in Parkinson's disease, without dementia, but just regular Parkinson's disease, particularly early onset. So we think of average age, say mid 60s for Parkinson's onset. People in their late 40s, early 50s will often present with executive dysfunction. So they might come to the office complaining about some cognitive issues. They don't know exactly what it is. They might say it's memory, they're having some word finding, something. Mini mental is not going to be helpful at all. Now, what's the best part of it? That's the 3 words. The 3 words is the best part and the most sensitive part of the mini mental. The other thing is, if you're using it, you're supposed to be paying, and I think it's $1.23 per MMSE that you give. So it's copyrighted. Fulstein went and copyrighted it. So it's not free. You've got to pay for it. And unfortunately, it's susceptible to education, to English as a second language, and it does not measure executive functioning. So it's got its limitations. And ironically, it's still being used by some researchers. I just read a 2018 paper, and the way they determined who was cognitively intact in an older cohort versus who had early dementia is using the MMSE. And that makes me call to question what they were calling cognitively intact. So the best dementia screening test, in my opinion, is the Mini-Cog. So the Mini-Cog, if you look on your left, and I'll go into this in a little bit more detail, you got the 3 words. So you've got the best part of the mini mental, and then you've got the clock drawing, which is an elegant test in and of itself. So you follow the directions verbatim. This is easy to give. It's got really good reliability. So test, retest reliability. You don't have to be specially trained to do this. So we have our medical assistants give it, and they do a fine job giving it. So it doesn't have to take a clinician's time, and it's also quick. You can do it in about 3 minutes or so. So here's the part for the words. Please listen carefully. I'm going to say 3 words that I want you to repeat after me and try to remember. You want them to repeat the words because many of my patients have hearing loss. They'll deny they have hearing loss. They've never had their hearing checked, and you've got a spouse in the background going, oh yeah, they've got hearing loss. So you want to make sure they actually heard the words. The other thing is use the recommended words. So you've got 6 different types of, or groups of words you can use. The reason you don't want to make up your words is you might make something very easy by mistake or more difficult than it should be by mistake. So always use the words that they say. And then you proceed with the clock drawing test. So the clock drawing test is your executive functioning. So this is your memory, that's your executive functioning. And then I put on the last part here, don't forget to ask them to recall the 3 words. So that's kind of a memory test for you. It's easy to forget to give the 3 words. Okay, so you gave the 3 words, they repeated them back. You know that they've got them in their brain. Question is, are they going to remember them? You give them the clock now. Now, we give a pre-drawn circle in the Mini-Cog, and if you look back here, go back one more, it's not cooperating. There, if you look back here, the size of the contour, the size of the circle is a half a page, and that's going to be important later on. Okay, next I want you to draw a clock for me. First put in all the numbers where they go. So you have them do that. And then I set the hands to 10 past 11. So Dr. Edith Kaplan in the, I think it was in about 1972, really popularized 10 after 11. And the reason for that, if you think about where's 10 after 11, you're using both sides of the circle. So both visual fields in a sense, and it's 10 after 11. So they have to think abstractly that the 2 is 10 after. And the other thing is on the left side, you've got the numbers 10 and 11. And if they are having some problems cognitively, like they're concrete, they might put the hands at the 10 and the 11. So 10 after 11 is the reason for that. That's what you do in between to have a distractor. And now can they remember the words? So you see how many words they can remember. It's out of 3, easy to score. Clock drawing, a normal clock is 2 points. A normal clock, the numbers are all placed in the correct sequence in approximately correct position. So I think of them as, are they in the correct quadrants? So again, if you think of your anchors as 12, 6, 3, 9, are the other numbers relatively in the correct quadrants? You shouldn't have any numbers missing or duplicated. And in the Mini-Cog scoring, because with the Mini-Cog, you can either score it numerically or you can look at it qualitatively. I do it almost exclusively qualitatively for my purposes, but if you're going to score it, the Mini-Cog is a very simple, easy way to score it. And with the Mini-Cog, hand length is not looked at. Now, qualitatively, that's a big deal for me if they reverse the hand length, but for this scoring, it's not. And the choices are a 0 or a 2. So there's no 1. 0 or a 2. So the score is out of 5. You can, anybody who's got, they say a cut point of less than 3, so that would be 2, would be someone who needs further testing. Remember, the Mini-Mental, the MoCA are screening tests. They are not meant to be diagnostic. So they're very, very important. They're just there to raise the level of suspicion and to give you a chance to do further investigation. And we'll talk about what that involves, whether it's a referral, whether it's labs, things like that. You want a little bit more sensitivity, go with the cut point of less than 4. This is not a perfect test. You've only got 5 points to play with. I interviewed a woman yesterday. She's got her bachelor's plus several hours in English literature. She's 77 years old, and she's been getting 5 out of 5 on the Mini-Cog for the past 4 years during the annual wellness visit that one of our primary care physicians gives. But she's got something going on, and I could tell from the interview, and we're bringing her in for testing. So it's not perfect, but it is a good test, a good screening test. So just to kind of summarize some of the points I've made, quick to administer, 3 to 4 minutes, easy to score, as you saw, 6 alternate word lists. There's one research study that actually has 3 different clocks. It takes the best part of the mini mental along with the clock drawing test. So it gives you visual constructional. Now, granted, the mini mental has the intersecting pentagon, so you get some visual construction with the mini mental. But more importantly to me, it's got the executive functioning. And it's not threatening to patients. Draw a clock. Now you might say, yeah, but that's an analog clock. We've got digital clocks. Yeah, that's true. But again, we're talking us boomers, right? We grew up with the analog clock. This test, the Mini-Cog with the clock drawing, is going to be relevant for many, many years, probably a good 30 years before maybe, and who knows, digital clocks will be the more relevant, and then who knows how we're going to test for that. The other thing that it's helpful for is you will often have the family member who says, there's nothing wrong with dad. I don't know why his primary care doctor said he needs to be seen. And by showing them an abnormal clock, you can demonstrate that there is a problem. Also, as with the lady I just gave you the example of, having serial clocks over time can be helpful. You can see, is there any progression? Now, in her case, I didn't have that luxury. So if you're using Epic or one of the other electronic medical records, please, please, please scan in the Mini-Cog into the media tab of your electronic medical record. Because for me, when that's available, I go right to the clock to see if there's any difference from year to year. That's very, very helpful. So let's take a look here. So what are the skills needed to draw a clock? And this kind of goes back, interestingly enough, to the history. So in 1915, that's when clock drawing was first used by neurologist Sir Henry Head. And he actually used it for aphasia. So it was comprehension. Did a person understand when you would tell them to draw a clock? So it was first used for that. It involves, of course, planning, visual memory. You've got to remember what does a clock look like. There's visual spatial. We'll have an example later on neglect, visual neglect. Visual construction. So that's another aspect, and a good way really, but nothing that you'd have time to do in primary care or in the community, is actually clock copy. So we have them actually do a clock, we give the contour like the Mini-Cog has, and then we have them copy a clock, and that can give us a lot of information. People with Alzheimer's often can't draw a clock, but they can copy a clock well. Numerical knowledge, so 12, 1, 2, 3. Abstract thinking, like I referred to, 10 after is that 2. Inhibition, they call that frontal pull. So the inhibition they're talking about is the 10 and the 11. So when I say 10 after 11, somebody who's looking at it concretely might put the hands at the 10 and the 11, and then just basic concentration. So when clock drawing really became, I would say, very popular and frequently used was about 1986. And at that time, a Dr. Schulman said, let's not use it just for lesion localization. So it was being used in stroke and brain tumors. Let's use it for dementia. And when you talk dementia, you don't have to be a neurologist. So it is more applicable to primary care, geriatrics, internal medicine, family medicine, and so on. So that's when it really became popular, and you'll see a lot of research on it beginning about 1989. So let's take a look at comparison here. So a couple ways to score. Now the clock drawing test does not have to be scored numerically, but if you're going to, the easy ones are the Mini-Cog or the MoCA. Those are easy scoring methods. Unfortunately, there's more than 20 scoring systems, and I actually reviewed them for a book chapter years ago. And after I reviewed them, I concluded, you know what, they all kind of have their advantages and disadvantages. Dr. Schulman's is well regarded, although in some areas of anticipating diagnosis, it is a little bit weaker. What I love is the qualitative, which research indicates is as helpful as the quantitative. So I use an error analysis. I look at the process. How do they approach the clock? Do they do 12, 6, 3, 9, or do they do 12, 1, 2, 3, 4, 5, oops, over too much, 6, and so on? How do they approach it? Are they erasing a bunch of things? Are they doing things like that? So this is the way Eknoyan, Park, Schulman, some of them talk about the types of errors. So graphical, stimulus-bound, conceptual, planning, and perseverative. And I'll go over some examples for you all to look at in a minute. So here's an example of a longitudinal clock, and I'm going to use it as within the context of the MoCA. So it's an 82-year-old man, also a teacher, 18 years of education, diagnosis of Alzheimer's, diagnosis of essential tremor, and a diagnosis of anxiety. So without looking at the clocks, what does that tell us? Was Alzheimer's, we're thinking memory, rapid forgetting, short-term memory. So the 3 words of the MoCA is going to be helpful with that. Essential tremor. So all the movement disorders are prone, including essential tremor, not just Parkinson's, are prone to executive dysfunction. And then what about anxiety? Anxiety tends to hit us cognitively at the level of attention concentration, which we saw is one of the things we need to do. So here's the clock, June of 2020. On the right is the clock, July of 21. So the way I approach this qualitatively is going to be different than how we approach it quantitatively. So look at those 2 clocks. We go to the next slide. All right, so again, if we look at clock drawing, Mini-Cog scoring, here's the first thing I recommend everybody does. So you look at the clock on the left, looks pretty okay, right? I recommend you actually go through and say the numbers out loud or say them to yourself. So 12, 1, 2, 3, 4, 5, 6, 7, 8, 9. Wait a minute, there's 2 9s. How many people saw there were 2 9s? 10, 11, 12. It's easy to miss. So you want to see, are you missing anything? So clock number 1, hand lengths look okay qualitatively, right? But they don't meet at the middle. Well, let's look at the score. Normal clock has all the numbers placed in the correct sequence, approximately correct positions. So the 3's a little high, but in general, everything's in the quadrant it should be in. No missing numbers, nothing's missing, no duplicates. Yes, we've got 9 duplicated. Hands are pointing to the 11 and the 2. Yes, they are. Hand length is not scored. So what do we have? A 0, 1, or a 2. You can only have a 0 or a 2, so it's a 0. 1 year later, what do we have? We look at those. We have no duplication. 12, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12. Hands are at 11 and 2. So ironically, a year later, he's got a 2. The year before, he's got a 0. So he didn't duplicate it. But look at what's going on. Let's look at it qualitatively. What's going on? So if we look at the one on the right, the hands are the wrong length, right? The minute hand's at the 11. The shorter hand is at the 2. He made an error also, and he kind of crossed it out. So what I'm especially interested in this year when he comes in is, will he make an error and then not be able to correct it? We sometimes will see that. Look at the one from 2020. There are some spacing issues, that you can see here, the 4 and the 5. But now these spacing issues have gotten even worse. So, I'm getting a lot of information qualitatively from this versus just what I'm getting from a score. So I'm not saying don't do the score, but what I'm saying is certainly look at them qualitatively. Because again, if you're looking at progression over time, these are important factors to consider. So some examples. What's a graphical error? Numbers are difficult to read. Well, we've got a bunch of little lines here, don't know what those are. Hands are not straight. We've got 2 parallel hands. They don't even meet at the vertex. And so again, look at your counting. So we're missing a bunch of numbers here. And then we see 4, 5, 6, 7, 8. Oops, wait a minute, 7, 8. So we've got repetition here, 9, 10, 11. And look what they've done. You see what they did was they went a little bit past the 11. That's their 10 after 11. Again, a literal type response, 10 after 11. So sometimes you see the hand pointing at the 10. Sometimes you'll see it like that. All right, what's a stimulus-bound one? So this is where the patient does not recode, if you will, the 10 as being the 2. And that's what happened here. And here they don't even really go to the 10 per se, but everything is just a little bit past the 11. You can have a 1 that's written either near or between the 10 and the 11. Hands may be absent and so on. Look at qualitatively, what else are we seeing? Look at the spacing problems. The 2's right next to it. Here you've got a huge space. The 1's over the 12, so I suspect they did not do the anchors. They started 1, 2, 3, 4, 5, and ended up with 12. Again, gives you good information. Conceptual errors, again, it's the loss of the meaning of what is a clock. So how many of you have clocks with one hand? Not very helpful. How many of you have clocks where the numbers are like this and then the actual time 11:10 is written in almost in a digital format like this? So here the person is not understanding what is the concept of a clock. Now this isn't short-term memory. It is the memory that we get from growing up. So we can't say, oh yeah, I learned a clock when I was 2.5 years old and I was crawling around on a hardwood floor in the kitchen and blah, blah, blah. As opposed to when we do the 3 words, they remember that we just gave them the 3 words. That would be called episodic. So this is semantic. It's a long-term stored memory. So there's degradation of that. And then errors planning or spatial. If you look up clock drawing test, you're going to see this in every single textbook. I don't see it that often. I hardly ever see that crowded like that. But let's say we do see it. What does that mean? Well, it could mean a number of things. One of them, it could mean that the person has some neglect. So as a neuropsychologist or as a behavioral neurologist, we're going to give some sort of a cancellation test to see, are they neglecting space? Or was it just really poor planning and they went from 1 to 12 and then knew that it wasn't anything past 12? Here's this 10 after 11 that we were talking about, where they've actually made the 10 the shorthand, the 11 the longer hand. So again, they've got that inability to think abstractly. And then this one is a little controversial. So the MoCA would actually score the numbers outside the contour, outside the circle as correct, as long as they don't go in and out. And a lot of scoring systems insist that the numbers have to be within the clock, because otherwise, you know, what's happening? How can these numbers just be hanging out on their own? So that one kind of depends on how you score it. But qualitatively, the clock seems to be pretty good otherwise. It's just that this is not a common response. In my experience, maybe 10% of my patients make that. And I'm not saying that scientifically, but that would be my rough guess. Not that common. And then perseveration. And we've seen a couple examples of that. That's repetition. So more than 2 hands, you can see sometimes writing numbers beyond 12. Again, use that count, you know, say them out loud so you don't miss something. 12, 1, 2, 3. And anyways, you've got 2 12s here. And then look at here again, they've lost the concept of the clock. So they've got a 1 hand and it's pointing from the 10 to the 11. This is an interesting one. So this is from the MoCA, and my one colleague, Heather Phil, who's our APN, gave this to a patient. So the MoCA, if you look at the top row, it's got 3 parts. And I'll show you a picture of the MoCA in a few. It's got this first part, which is like the trail making test. It's set shifting. So the example is you draw a line from 1 to A to 2, and then basically you tell them to keep that sequence going. So you would say 1 to A to 2, 2 to B to 3, and so on. Then there's a copy that they've got to do of a cube. It's called the Necker cube. And then there's a clock drawing. And it's a freehand clock. They draw their own circle. Look at what they did here. They've got 12, 1, 2, 3. I guess that's a 4, 5, D. And then I don't know what that is. So basically this task here influenced their performance here. So that's a type of perseveration we call proactive interference. a task in the past is interfering with the current task. Very important when you're looking actually at decisional capacity, because what do we do when we make an informed decision? We basically are looking at our pros and cons, right? But if I am doing that and weighing pros and cons, but a bunch of pros or cons from another task that I did that have nothing to do with the decision at hand are part of this group that I'm looking at because of this proactive interference, I'm no longer making an informed decision. So that's part of what we look for when we do capacity evaluations. Okay, some case examples. Number one, this is a 71-year-old artist. He's got an essential tremor. Remember, I said there can be cognitive changes with essential tremor. And he's a candidate for a type of surgery we do called deep brain stimulation surgery. It's basically putting a pacemaker into the subcortical regions of the brain, helps with some of the symptoms, tremors, things like that. Not a cure. The disease still progresses. Essential tremor is a little bit different than Parkinson's, but Parkinson's still progresses. This is the clock he drew. I have to make sure he does not have dementia. If you have dementia, you do not get this surgery, because the idea is doing brain surgery on a brain that already is compensating as best as it can because of dementia will get exponentially worse. So what do you think of this clock? So he's got 5, 10, 15, 20, 25, 30, 35, 40, 45. So this isn't even in the right quadrant, even if you were to argue that. But what happens here? 58, maybe it was 59 and he changed it. 58, 59, he's got a 1 here. Wouldn't this have been a 0? In other words, major problems, right? This is not a normal clock. And you can't say, well, it's military time or something. No, this is an abnormal clock. So this poor gentleman, he's coming in for a full neuropsych battery, and I hope he does better, because based on this, I would say he's not a candidate. Here's another example. This is one patient we saw over 2 years. And interestingly, what's written on here, our technician, who are called psychometrists, noted that the person was kind of confused as to which was the hour hand and which was supposed to be the minute hand. And you can see they're pretty much the same length. So in 2005, they kind of get through it. I mean, there's some spacing issues, the 4 and the 5, for example, but not horrible. Look at what happens in just 2 years. We've lost the concept of a clock. We don't have the hands. And look at the numbers. What's happening to the numbers? 12, 11, 10, 9, 8, just in 2 years. So usually with Alzheimer's or disease like that, they're usually progressive and slowly progressive. Some of our younger patients, though, we see rapidly progressive Alzheimer's. It's actually very scary. We had a 59-year-old, and she had Alzheimer's rapidly progressing. I tested her 1 year when she first came in. The rest of the time she was seen by a behavioral neurologist. I really wouldn't have been able to test her. She deteriorated very quickly. She died a few months ago. Just very, very sad. And then this is an 81-year-old psychiatric nurse, really intelligent lady, gave me a wonderful interview. I mean, from the interview, I could not tell there was a problem. Very informative, very thoughtful interview, and this is her clock. And she gave you 2 clocks, actually, but this is her clock. And you see there's no 12 in either of them. So we've lost the conceptual part. We've got the graphical errors. We don't have the hands. A lot of errors. And then this one's kind of an interesting. This is an 84-year-old. He's an accountant and he's a professional cellist. He actually toured in Europe. Really bright gentleman. Again, gives a wonderful interview. No idea he's having problems, other than they tell me he's having some problems with memory and things like that. But it, sounds like could be normal aging on the interview. And we do a pretty thorough interview. We have the luxury of doing interviews that can last anywhere from an hour to 2 hours. So from the interview, other than the family member was really concerned, couldn't really tell just talking to him. And if you look at that, the 2 hands are pretty much the same length. They're at the 11 and the 2, but no numbers. Where do the numbers go? There's some research also suggesting that when you have these lines coming out from the center, almost like a wagon wheel, that's more commonly seen in vascular types of disease. So just be aware of that. So what do we do with an abnormal Mini-Cog? Remember, it's a screening test. It's not diagnostic. So we need to roll up our sleeves and look at the usual suspects. So for physicians, we want to do lab tests, a CBC, ESR, see if there's inflammation, chem panel, thyroid stimulating hormone, low vitamin B12, very, very important. B12 is often not ordered by primary care. It needs to be if it's low. I mean, we use 400 as the minimum that we want to see, then we need to increase it. A brown bag medication review, what's that? Open your medicine cabinet, get a bag and throw everything into that bag and bring them to my office to look at. You want to see everything this person's taking, including the medication that was prescribed in 2007 that they're still taking on occasion just to be on the safe side. You want to do the shake test. So if there's a 30-day supply and it was prescribed and picked up in April and it's still full, that's a concern. Or like when we did that informally with my father-in-law, there were 6 different pills in there and he couldn't tell me what any of them were for. And was managing his own medications. The other thing is over-the-counter medications. The bane of my existence are sleep aids. So Kirkland sleep aid, Tylenol PM, Bayer nighttime. What's wrong with them? They're over-the-counter, right? They must be safer. No, they're anticholinergic. Anticholinergics cause constipation, cause problems with gait, balance, and can cause confusion. So sometimes we get them off of that and we've taken care of a lot of problems. If they've got a sleep problem, let's send them to a sleep specialist. Let's work that up. 1 in 3 Americans has a sleep disorder. 2 out of 3 people with a movement disorder, particularly Parkinson's, have a sleep disorder. They are not really being screened for as they should. And sleep apnea, I had 2 patients years ago, 175, 180, 80 years old. I tested both of them. They looked like exact textbook Alzheimer's disease, rapid forgetting, one other area affected. But in my interview, I do something called the stop bang, which is just a series of questions that indicate if someone's at risk for sleep apnea. Both were. I sent them to one of my sleep colleagues. He investigated, decided, yes, they both had sleep apnea. They were candidates for CPAP. I saw one at 6 months. I saw one at 1 year. Their neuropsych testing returned to normal. Now that's my dramatic example. Not everybody benefits to that degree, and that's over 26 years of doing this. But boy, it drove the point home that we need to be looking at sleep, particularly sleep apnea, and treating it when we can. Sometimes if there's a dementia, it's too advanced, you can't, but be aware of that. Neuroimaging is often indicated. And then for complicated patients, you want to refer to a specialist. So that would be geriatrics, neuropsychology, or a neurologist specializing in dementias. Not a general neurologist, they don't have the training, but someone who either does behavioral neurology or geriatric neurology, someone who sees older adults and does dementias. Very, very important to get them to the right specialist. Other cognitive screening tests. The other one that's wonderful is animal naming. Takes about a minute because that's all you give them. And you basically say, I want you to name all the animals you can in a minute, hit the stopwatch and start writing. You start writing, they say them verbally. And you want to see how many animals can they say in a minute. 14 or more is considered normal as far as this goes for a screening test. We use it in neuropsychology where we have more strict norms, but if they get 14 or more, that would be considered normal. And then there are some rules. You don't count like immature examples of an animal like a dog and a puppy there, but humans are considered animals. If they start giving you kinds of dogs, that's okay. So Airedale, Labrador, and so on. So you want them to get at least 14 or more. We tell our primary care physicians, give the Mini-Cog, add the animal naming for a little bit of more sensitivity. By itself, it's actually a pretty decent test. It is pretty sensitive and specific as a screen for Alzheimer's. Here's the MoCA that I've been talking about. So one issue with the MoCA is, unlike the Mini-Cog, which is free, you pay $125 for training to give the MoCA, and you have to do that every 2 years. The other thing, it's a good test otherwise. I mean, it kind of covers the different areas. So at the top, you've got executive functioning. I showed you this before. You've got some animal naming here. You've got the words. And one thing I really like that they do with the words is if you don't recall any words, they'll give you a cue. So one of the words here is face. If you don't recall face, after you've given the other words, you say, or give them a chance to say the other words, you say, well, one of the words was a body part. And then see if they can get that. And then if they can't get that, you give them a multiple choice. Can they recognize that? That's important because in Alzheimer's, that doesn't help. They're not going to help. Cues aren't going to help them. They're not going to be helped by multiple choice. Parkinson's disease, they might not recall any of the 5 words. You give them category cues, they're probably going to remember them. They might get all 5. They might need a multiple choice, but so it is helpful. The thing I don't like about it is the clock size. It has a small clock. So each of these are a page, Mini-Cog on your left, MoCA on your right. Look at how little the clock is. And let me give you an example of a patient I recently saw. I tried to make these about the same size as they are in real life. But look at the MoCA. Now, granted, that's an abnormal clock, 1, 2, 3, 4, 5, 6, 7, 8. But look at what the bigger clock brought out. I mean, there's a bunch of potential neglect here, which we don't see in the small clock. So for example, when my behavioral neurologist gives the MoCA, he always gives a large clock as well, as I do. So in summary, it's very, very important to screen for cognitive changes in our aging population. And unfortunately, most people, 16% is the percent, most people are not screened. So very, very important to do that. The Mini-Cog is an easy to use tool. Number one, it's free, which is always a good thing. Number two, minimal training. So your medical assistant can give it very well. It's got the 3 words, which is good for the Alzheimer's type, the rapid forgetting. And it's got the clock drawing, which is the executive functioning, which can also be a problem in Alzheimer's as well. It's just that the memory is usually first. But executive functioning, very important in vascular dementia, very important in frontal temporal dementias. Consider adding animal naming test. It gives you some verbal fluency, but again, it's also a good test for, it's got the executive functioning part, because you have to think, okay, just animals, not vegetables and things like that. So that's sorting part to it. So it's a good test. Remember that an abnormal screening is not diagnostic, it is a screening. So it mandates further evaluation. If somebody has a urinary tract infection, they might not do well on this test. And hopefully somebody knows they've got that, but you've got to look for, through their labs, for what's going on. You want to do a medication review. I mean, medications are such a problem, and I suspect you all know this, but anyone using an EMR like Epic, the one thing we teach, and I'm a super user with Epic, one of the things we teach our new physicians is the one area that's always inaccurate is medications. So we need them to either be bringing them in once a year, but going through a list is not helpful. Neuroimaging, appropriate referral, so geriatrics, neurology or neuropsych, or sometimes all 3. And I would just encourage you, give clocks, give them all the time, give them to patients who you think are completely intact. If you got little kids, give them to your kids just to see what they do. I assume they still learn how to do a clock, but I mean, give it to everybody, because it's through experience that you're going to start to appreciate the types of errors people can make. And that's going to really help you be, in my opinion, better able to interpret not only does the person have some sort of cognitive impairment, but most likely is it looking more like an Alzheimer's? Is it looking, for example, more like a frontal temporal dementia? To what extent is visual spatial? And once they do the full testing and so on, what do we do about that? Well, in our clinic, we've got neurological occupational therapy. So depending if they're MCI, but they're having these problems, they might see our neuro-OT person for some of those visual spatial issues. For some of the cognitive issues, they might see one of our speech therapists who also do cognitive rehab as well. So these are helpful in many respects. So please give the clock, give it often. That's the only way you're going to be comfortable with it. Even better, give the Mini-Cog at animal naming. Now, if you Google the following, I wrote this down: memory screening in the community. Memory screening in the community. The Wisconsin Department of Health Services has a wonderful booklet on almost everything I just talked about. I just found it just before I was about to give this talk, actually. But it goes over a lot of what I've been talking about. They started with animal naming, and they're doing Mini-Cog animal naming. They've just done some wonderful research, very practical, that you could use in your settings. So that is my talk. I've